So today, welcome to our next in the series, Small Talk. This one today is about heart failure, but it's really about patient self-management, supporting better outcomes. And we're pleased to welcome our presenters today. We have Nikki Piermont, who is a clinical nurse specialist and health advocate for Lifespan Healthcare System. And Mary Biello is the transition of care specialist, a transition of care specialist for visiting nurse, home, and hospice. That's a lot to say, Mary. Next slide, please. We always put this in here, one of our standard slides, in case you're not familiar with it, where to find chat and the mute button. Next slide, please. We are being recorded. You should have gotten a pop-up that says we are recording this for future listeners. We do want active participation. Just reminder to keep yourself on mute while there's presentations going on, but we will welcome you to come off mute, ask questions, and you can also use chat as well. Next slide, please. And before I forget to mention, Maureen Marcella from our team is in chat. She'll be monitoring that and helping to answer questions. And when we get towards the end, we'll open up not only the mute, but also whatever's in chat we'll talk about. This is a standard slide. If you don't know who we are, the IPRO QIN-QIO is a federally funded network. We cover 11 states in DC, and please go to our website to find out more. Next slide, please. Okay, so our small talks are just that. They're really meant to be cognizant of your time. We usually take about 20 minutes to address a challenge, give you an idea for an intervention, and then we hope that you walk away with an idea for how to have an impactful outcome. Next slide, please. For this one today, our challenge that we identified was that patients with heart failure who are discharged to the community are at high risk for readmission. The intervention that you'll hear about is really focuses on, there's a tool that's for self-management, but it's more than that. It's more than just a tool. It's more about collaborating across settings. And you'll hear about how there was standardized education across settings for the clinicians, and then also they used a standardized tool and how that impacted self-management when the patient was discharged. And the result that we're hoping for is that engaged patients and families who manage their conditions and are aware of what to look for, the red flags, hopefully they're less likely to have to require a readmission to the hospital. Next slide, please. And as we all know, readmissions lead to CMS penalties. Obviously, patient outcomes aren't so great if they're having to return to the ER frequently. We know the cost of hospitalization is a burden on our healthcare system. And we know that multiple chronic conditions are risk factors and result in rehospitalization. Next slide. This is just an excerpt from one of our state reports. We have access to Medicare fee-for-service claims data. This happens to be Rhode Island. This is from October 2020 to September 2021. We create these reports for all of our states and our stakeholders, hospitals, and we distribute them quarterly. But this particular slide just shows you that this is something that we see continually, and it's not just Rhode Island. The main diagnosis for admission to the hospital, heart failure and septicemia. And our reports look at the top 10, and these two compete for the top just about every quarter. But we also know that the top readmission diagnosis is heart failure as well. So that's how we landed here today. Next slide, please. So I am going to turn it over, just a little bit more background from myself. Both Nikki and Mary have, for some number of years, have helped to co-lead community coalitions for safe transitions in Rhode Island. Mary was involved in a work group from one of the coalitions several years back that developed the tool that you're going to see today. It's been modified. It is in use in some of the part of the Lifespan system, and it's used in home care. So we're glad that you're joining us today. It started out as a pilot program. People at the table to develop the tool were from hospital, nursing home, home care. There were train the trainer programs, and it was rolled out, and with the idea that everyone would use the standardized education tool and patients would hear the same message regardless of what setting. So I'm pleased to turn this over now to Nikki Piermont. Next slide, please.
Hello, good afternoon, everyone. Just to put a date on it, we actually did the Train the Trainer for heart failure for the education tool in 2015. And we did quite a bit of quite a few classes statewide, and we did one like very large venue. Mary was there as well through it all. And then 2016, we did COPD with the similar principles. So we just thought it was time to kind of refresh. And there's been some turnover in roles in different facilities. So we thought it'd be great to just have a refresher and get everything reinvigorated since the pandemic is slowing down a little bit. So just kind of going over the adult teaching principles. I think we all do this through some types of assessment as nurses when we meet with our patients. I know the nursing staff here, and physically I'm at Newport Hospital, just to tell you where I am. So we look for, when I meet with patients, how they best learn. I always ask them that and look for positive reinforcement. Obviously, we always tell them like what they've done well and maybe some opportunities for improvement based on their physical condition because they are in the hospital, so something went wrong. Integration and connection, so just making sure that the family is very involved, and we make sure that the patient and the physician and the nurse and the physical therapist, whomever is on the healthcare team, dietitian, very important with heart failure, is very involved with the patient and making that connection and rapport. Learning must be relevant. So we're constantly looking at the tool, which I'll talk about in a second, is on a pretty low grade level, but just making sure it's relevant to what we're talking about. And I do work with cardiologists to review that as well. Solving problems, some people learn best by that. I'll talk a little bit about teach back in a minute, but definitely if I can get in there and go over patient-centered individual items with them, they listen a little better because it's pertaining to them and their results. And memory overloaded is a problem usually in the hospital. I do follow patients at home, not physically, as I tell them. I'm not gonna like be there at their house, but I follow them telephonically because they're not really learning very much in the hospital. They're very overstimulated while they're here, and they have a lot of hands in the pot. So I just kind of look at the teaching here as an introduction, and I'll be reinforcing that along the way. Next slide, please. For most patients, definitely the skill level is what we're looking at. I was looking at the grade level. It says here average high school graduate. We find that we actually go even lower to like sometimes a 5th to an 8th grade level in that range, which is really difficult in describing like things like ejection fracture. I know diabetes with hyper and hypoglycemia, hypertension. So I do a lot of defining because I want the patients to know what those words are, even though they're at a higher grade level, and our materials definitely are on the lower grade level. They're very simple, very large font, as you'll see in a second. Next slide, please. We do use the teach back method. I tend to do that as I go. So I call it kind of more of a tell back method, like tell me what you've heard me say to you. And it works really nicely. So that way I kind of know exactly what they're retaining and what they're not, what they're getting. I think this is a really useful method to kind of assess what the patient has heard you say, because I think you'll find, and many of us do, that what they're actually retaining and heard you say is not the same. It's like that telephone game with the cans that we used to play. I'm dating myself when I was younger, but it's interesting to see what they retain. And then we also have to do that with the patient and their caregiver, almost, especially the men. Almost all of them have a primary caregiver that's usually a wife. And then the women tend to have either a husband or a daughter or a child. And when to use teach back, I use it all along. So I use it through my whole process of educating. And sometimes it's not possible or appropriate, but then usually I can always find someone to do it with. Return demonstration is a little tougher. I do give a lot of written materials, as you'll see my main tool in a second, but pre and post tests are also pretty effective. So sometimes I'll use that as well, just to kind of see what they've retained in their teaching. And I can tell by following them long-term also like what they're retaining and what they retained and they knew it and they slipped back on through the time. Next slide, please. I feel like Vanna White. So the integrated model for chronic disease. So we want to make sure, and I talk about this a lot in every venue, that we're doing patient-centered care. Goal setting, I always describe this to my students as what is important to the patients. And I ask them that, like, what's important for them? Usually it's just like the number one, I don't want to be in the hospital. Like especially if someone's coming in like 3 times in the past month, their goal is not to be here. They don't want to be here. I think the days where patients were packing their bag and wanting to be in the hospital are gone. They truly find it inconvenient. They're a little fearful of the COVID stuff that's happened over the past couple of years and being here. So I really talk to them about what's important to them and their loved one. The self-management is huge. Obviously, I start that in the hospital. I start them being engaged in their weight process and making sure they're weighed every single morning, and they track along with the staff and myself. The zone tools, we definitely assess health literacy as we just talked, motivational interviewing, again, engagement, teach back and tell back, and scenario-based learning. If they're visual learners, I tend to, like in their computer savvy, which a lot of people are nowadays, even my 90-year-olds usually have a smartphone or some type of computer. I will use some web-based learning as well. If they like little video clips, it just kind of helps reinforce everything. Next slide, please. Sorry. Clear information increases patient engagement and empowerment. I can't emphasize this enough. I love to empower people. When I meet with them at first, and then I go back and I see that they're writing down their weight on a weight tracker, and they're telling the nursing staff or the home health aid staff, the CNAs, you didn't weigh me, I'm standing up. I want to be weighed standing up because it's more accurate. So like, to me, that shows me that they're engaged and they're empowered and they're advocating for themselves. So like, I know that that's immediately a good sign. Next slide, please. Oh, at this point, I just wanted to make sure that we're asking, and you guys can answer in chat because it is being monitored, what patient education tool for heart failure or any other chronic disease that supports self-monitoring and empowerment, and some of the principles we just talked about are that you may be using in your facilities. So if you could just respond to that question in chat so we can talk about it a little later. I think one of the things that we had talked about in doing this is that we shared through the Train the Trainers, this tool that I'm about to talk about statewide. So we actually distributed it, emailed it, but there has been some turnover. So we just wanted to make sure that, that you guys all know that this tool is available, and that if you're new to the facility, it may be there and you just didn't know it, but we're going to reshare it in a new format, and that will be available to you. So just asking what tools that you're using in your facilities. Next slide. So care transitions intervention, this is really my department, CTI for lifespan wide. We have a pretty large department. And this slide is based on Eric Coleman. He's really the guru of care transitions. He has an amazing website that has tools for both health professionals and patients that you can print and use. So I just wanted to kind of go over the 4 pillars really quick, or just have you see them on the slide, because this is pretty much the principles that we all live by. Any of us that are doing patient contact as nurses at the bedside in the hospital, followed it at home care, RN care managers in the doctor's offices. This is exactly what we're doing when we do transitions of care. And we're really making sure that the patients know their medications. We have pharmacists in our department that the patients can meet with. I know visiting nurses that I work with closely on a Quinnipiac Island also has pharmacy service that can go to their house and go over that. So empowering the patient on their medication management and making sure through med reconciliation and their own med management that they're doing things correctly. My glasses. Dynamic patient-centered records. So just we have the My Portal, My Lifespan. A lot of people are signed up for that. They can see everything. We have full transparency to all their progress notes in the hospital, all their test results. And so sometimes they're looking at that, not really understanding what things are. So sometimes I think of myself as a translator and explaining things to patients and making sure that they understand what they're seeing in their medical record. Again, it's all about empowerment and patient informational caregiving. So making sure that the caregiver is involved if they have a caregiver. follow-up, making sure that the patients have appointments with their PCP specialists. Some people don't have a PCP. Some patients haven't seen their PCP in 2 years. Some people have 10 different specialists that they're seeing. So making sure that they have follow-up and they're not so confused on who to see when. I find when people come in with a certain condition that they are concerned with seeing that specialist for that condition, like cardiology, before their PCP, which makes perfect sense. But I also encourage them to see their PCP as well. So they're in the loop since they're the ones kind of coordinating all of this care. And patient empowerment to be active and participating in these interactions. I don't see a problem with that with too many patients. They're going to their doctors, they're interested in what they have to say, and they're bringing a caregiver with them to hear and reinforce as well. And red flags goes right into the teaching tool we're going to talk about in a second. Teaching the patient and their family what red flags to look for with these conditions so that they know when to call either visiting nurses if they have visiting nurses, or any of the medical, their doctor if they don't have home care. So like knowing when that they need to seek help in the red flags of their condition that they're hospitalized with. Next slide, please. So I'm not going to go over obviously every page of this. We just wanted you to see what this looks like. This is the My Health Plan taking care of heart health. This is an education tool that I bring to the patient at the bedside. If I miss them at the bedside, I will mail this to them after I talk to them on the phone. And my version actually has my contact information on the font in the big font. So this is modifiable to your institution. And that's one of the things when we did the trainer, we wanted to make sure was happening that you could actually take this electronically and place your information on it if you wanted to, or keep it as is through the Safe Transitions Coalitions, and it's through a collaboration, but you can fill it out. I always fill it out for them, and I always start the weight tracker ahead of time for them too. Next slide. So this is the important part. This is the zones that we really delve into and teach the patient through any platform where the patient may be, either inpatient or through the doctor's office or through home care. Even the skilled nursing facilities have this tool. I know they've been a little overwhelmed the past 2 years, like all of us, but it is there. And with the heart failure patients do go to sometimes short-term skilled nursing facilities for rehab. So we really focus on this tool. And this is where I'm focusing more on like a good day, which is the green zone, a yellow zone, which we need to like kind of look at, like, you know, how do we get back to the green zone? What happened? And then the red zone, if they progress, they need to seek medical attention. Next slide. So this is kind of where I live in the hospital. This is the weight tracker. And I start this inpatient when I go to the bedside. I put their weight every day while they're in the hospital. And that, like I said earlier, I referred to the patients really getting engaged and empowered. And I get excited when they have it open to the page and they're tracking along with the nurses. And they're like, wait a minute, I gained 2 pounds. That can't be right. I'm on, you know, IV diuretics and I feel much better. Can you reweigh me? So they get really, that excites me as much as maybe they get excited. That just shows me that they're engaged and empowered. When they go home, I ask them to bring this to the doctor's appointment with them. I do a lot with visiting nurse, home health, hospice, because they're in the Newport County area. So if the patient does choose their organization, they have a home health monitoring system, a telemonitoring, where they can actually have the weight and the blood pressure and their pulse ox and the heart rate checked every morning, so that they can follow along and use this tracker along with that monitor as well. And we do definitely, like sometimes I will call the doctor for the patient if they've gained weight, but like the ultimate goal is the patient will be seeking their own medical attention if they gain within the parameters. It's like 2 to 3 pounds overnight, or the 5 pounds within the week. They can usually feel it too. I just tell them that usually they see it on the scale before they see it on themselves. And next slide, please. So the medication record, these are some other components that are in this booklet. Medication record is in there. I find most people have like a little list of their own that they carry, but there is a nice one in the book. It was a little small at first. We have made it much bigger and longer. As you know, some people are on about 28 medications. The diet, there's a whole diet section talking about foods and salt. I do have a great cookbook I give to patients as well, that I can share with anyone that wants it. I have it electronically. It's called Don't Pass the Salt. The patients love it. When I call them back, that's the one thing that they tell me that they really like. And then learning how to read the labels. For every single patient that's in Newport Hospital with heart failure, I automatically order a dietitian consult. So they reinforce what this book talks about with diet, what they're actually eating. And a lot of people aren't using the salt shaker. It's the hidden foods that they're not realizing the salt is in foods that they're eating every day. Exercise, we don't have cardiopulmonary rehab here at Newport Hospital, but we do have great ones still through Lifespan. I know South Coast has them as well, because there's a lot of the South Coast cardiology patients that come here. So exercise is a little scary for these heart failure patients at first. They're not sure what their parameters should be or how they should feel. They're a little scared. So the rehab, our home PT rehab, is a great thing for them to get so they feel more comfortable. Next slide. And having a good tool in one facility isn't enough. We have to continue, through the continuum of care. Like I said, I know that the practitioners I work with have the tool that I use because I talk to them a lot. Sorry for all of you that are bug all the time, you know who you are. So like if I don't catch them in the hospital and they do have home care, that's great. I can follow up with home care and collaborate with them to make sure they get the education that they need and the reinforcement, and also through the PCP offices as well. They have this tool. I don't follow patients that go to the skilled nursing facilities, but I do at least the standard of care in the hospital of looking at the patient. Newport's small. I have the luxury of really looking at the census and picking up whatever patient and making sure they have at least the standard of care, even if they're in an assisted living facility or a nursing home, of having the daily weights on a stand-up scale if they can do that, the registered dietitian consult, and the cardiology consults. So reinforcing and using the same tool as much as we can is great. And I think that we're pretty much all using the what do we call it? The green, yellow, and red. I know those tools are everywhere in models, COPD. I know I use them too. And I've been to some visiting nurse facilities where they have just like racks of them using that same concept. So that's really great. And teaching patients the red flags on any of their conditions. Next slide. I think that's going right into Mary. I just wanted to say too that I do collaborate quite a bit with visiting nurses in home and hospice that Mary works at, and using the home health monitor program. And Mary wanted me to mention what I've been doing lately is Patty Slavey, who is the home health monitoring nurse at the station. I will talk about it if they choose that facility for home care while they're in the hospital. Then they go home and they're excited about having the home health monitor because I've like introduced it to them. And then once they get on the monitor, they send me the vital sign trends weekly so I can follow along with how the patient's doing. Sometimes I'll even intervene. I'll coordinate with the nursing supervisor to make sure that my intervening is okay because they are in there with the patient. And then I do put the vital sign trends in the record. So that way the doctors and the nurses at the LPG offices and primary care offices can see it. You go, Mary.
Very good. Thanks a lot, Nikki. So we do have a patient that we share. Mrs. B is an 87-year-old female. She's alert, oriented. She's a widow who lives alone, but she does have assist of a private caregiver who lives nearby. Her diagnosis of congestive heart failure came about in October of 2021. She was introduced to the congestive heart failure tool at Newport Hospital when she was admitted there. But in addition to congestive heart failure, she does have diabetes, stage 4 renal failure, COPD, anemia, macular degeneration. Does she sound familiar? Neuropathy, osteoarthritis. So she pretty much has the trifecta when you think about coronary artery disease, as well as diabetes and stage 4 renal failure. That makes it very difficult to manage and keep out of the hospital. So we admitted her to service for skilled nursing PT, as well as for the dietitian to go out and assist her once she's home. It's appreciative that it starts in the hospital, but as you know, people do hear and learn a little bit better once they get home. She's also followed in the community by a cardiologist, a nephrologist, as well as an endocrinologist. So she does have a very busy life. This particular patient, I know Nikki has touched upon, we do collaborate using the telehealth system, and we do have a lot of patients on it, but this particular patient declined. She has her own electronic cuff and scale, which she tracks her vital signs, weight, and records daily. And that's very helpful. In addition to the congestive heart failure tool, where she does put the weight in, and is able to identify which zone she is in. We kept her out of the hospital till we did pretty well with her. At the end of November, her blood pressure started to increase systolically. We were able to keep her home by introducing a new blood pressure medication. However, at the beginning of December, then she started to have asymptomatic bradycardia with her heart rate hovering at times in the upper 30s and 40s. We were increasing our nursing visits at that time, as well as our contact with the cardiologist and primary care doctor. And we're able to keep her out for a couple of weeks, but unfortunately, she ended up back in the emergency room with shortness of breath. She was transferred from Newport to another facility because of the bradycardia to be evaluated for a pacemaker. They did determine at that time that it wouldn't be necessary because they felt her bradycardia was attributed more to her electrolyte imbalance. They did, however, want her to follow up with her nephrologist for her anemia to get her started on a IPRO QIN-QIO regimen. So she was discharged back home, and we resumed her and kept her home for an additional 6 weeks with a stable weight, blood pressure, and heart rate with the parameters that were established by her cardiologist. Ended up back in the emergency room at the beginning of January after a syncopial episode where she fell and hit her head. At that point, she was discharged home on a cardiac event monitor and was readmitted to a hospital at the end of January with a diagnosis of AV block, and a pacemaker was inserted at that time. She did discharge to a short-term to a skilled nursing facility for short-term rehab, which she did well at, and the congestive heart failure tool and education continued. And when she came home in the middle of February, she was resumed on her nursing, PT, and OT. Her fatigue was less, her energy was better. She was able to be more participatory in the physical therapy regime. That's probably because of the IPRO QIN as well as the pacemaker. Her skilled nursing visits were bi-weekly, then weekly, then every other week, to the point where she was just recently discharged. So she has not been back to the hospital since the end of January when they put the pacemaker in. So nursing did discharge her, and PT continues to follow her, more so for her osteoarthritis issues that she's not a surgical candidate to have repaired. I do view her as a success. I know she did have some hospitalizations, and she has, probably contributed a little bit to the data that we were seeing earlier. But at this point, she's been out of the hospital for more than a couple of months. And I think that's because, and can be directly attributed to, the follow-up that she's had and the collaboration that we've all had together, the hospital, the skill facility, as well as the cardiologist and primary care case managers, who are in a very, very important part of managing patients who have all of those, comorbidities, in particular, as Lynn likes to say, the trifecta. So that's our patient.
Thank you, Mary. Next slide, please. Maureen?
Okay, everyone, please, can you hear me?
Yes.
Please unmute yourself or use the chat feature to share any questions, ideas, success strategies, and or any lessons learned. I will tell you that in chat, when we ask the question about what tools you might be using, Mary put in that they use CRAMS, and Nancy put in that they use Chapel Hill Congestive Heart Failure Education Packet. If you'd like to come off mute or chat in what those are, I actually do not know these two teaching tools for patients.
You go to the next slide as well, Ryan.
So one of the other things we're looking at is, are you currently sharing any patient education tools that support the self-management across all settings? And if not, could you use these tools? We will provide the tools that are reflected in this presentation. And also, Nikki, you did say you would put the link to your cookbook in chat. If you could do that now, that would be great.
Next
Let's
slide,
see.
please. So we are at 12:30. Thank you, Maureen, for summarizing what we've seen in chat. Let's see. I think that we'll have to move along and just close this up. Well, for our leaving in action, I just wanted to say that, as Maureen just said, it might be time to think about reconnecting with your post-acute providers. Is there an opportunity to use similar tools, especially zone tools? And just so there is a continuation of the messaging that's going to patients and encouragement for them to do their self-monitoring. Next slide, please. Okay, and there's some additional resources as well that we thought you might find helpful. Next slide. Okay, Nikki and Mary did share their contact information if you'd like some more information, particularly about what they've talked about today. Next slide. Our website, you'll also find our resource library. I believe Maureen may put that into chat. That's where you'll find the Taking Care of My Heart booklet that was referred to today if you're looking for a such tool and would like to see what that one's about. Next slide, please. We also would be remiss if we didn't mention the boosters. This was about heart failure, but we try to, at every chance we get, to just promote the information that's out there. We've done some education. There's been some tools created, so you can also contact us for more information on that if you don't find what you need on the CDC website. Next slide. There will also be a link for the evaluation of this. It helps us to plan other short, small talks. And next slide shows you what ones are coming up. We've got some other ones in May and June. Hope you can join us as well.
And I did put the link in chat for the SurveyMonkey evaluation. If you would complete that for us, it keeps us relevant and making sure we're teaching what is relevant to you folks out there.
Great. And I think at that, we're going to close to be respectful of your time. Thanks so much to our presenters for some valuable information. Reach out to them, reach out to us if you'd like any other information resources, and we hope to see you again soon. Thank you.